The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. We're gathered here today again for the next episode of TMD Demystified. I am Tony Urbanek, and today I've chosen a very simple concept and very simple topic that can be applied certainly to many areas, but in this particular case, I wanted to apply it to my chosen field of activity, which is TMD. So the title of today is Obnosis and TMD, Observing the Obvious. Obnosis is defined, obnosis, O-B-N-O-S-I-S, obnosis, is defined as observing the obvious, to look rather than listen, to look rather than think, to see what you see and not what someone tells you to see. Let me repeat those again, because I think every mother and grandmother probably would use the same common sense kind of thought process when it comes to educating their children as to how they need to look at things and solve problems or decide what's right or wrong or what to do and what not to do. So if you have a problem to solve, if you need to figure out what's going on, it would be better to look rather than listen to somebody else, to look rather than to just think about it, but to see what you see, to observe the obvious, to see what you see right there in front of you, and to see what you see and not what someone tells you to see. All right, how does this apply to my chosen field of treating TMD? Well, the last episode, and this is kind of a springboard off of the last episode, or previous episode, I talked about the other kinds of treatment theories behind the treatment of the symptoms of TMD. And again, let me just repeat what I've said many times before for this episode. If you're new to the podcast, what is TMD? TMD is consistent inflammation within the temporomandibular joint, inflammation and concomitant damage due to the inflammation within the temporomandibular joint, which creates a series of symptoms. The inflammation creates the symptoms directly, and I've talked about that. And what are the symptoms of TMD? Frequent or recurring headache, earache, jaw pain, neck pain, tinnitus or ringing in the ears, subjective hearing loss or fullness in the ears, vertigo, dizziness, upper shoulder and upper back pain, arm, hand, finger tingling and numbness, and various kinds of locking. So patients consistently complain of one or more of those symptoms, which are more often than not hooked together. They happen simultaneously. And so the diagnosis of TMD can be easily made if the joint is inflamed and it hurts to push on the joint, and they have one or more, usually many more of that list of symptoms, they have TMD. That is the definition of TMD. Now, there are many treatments that have been out there for decades regarding some or all of these symptoms. And so regarding treatment of TMD, the issue today is, do you want to look at what you're looking at, or do you want to listen to what someone else has to say? I have claimed, and I state consistently and empirically, don't believe me about what I talk about. Look for yourself. Obnose for yourself. See for yourself whether what I say works, whether it is effective, whether it is true for you. And if you do that, you are obnosing the situation. You look at what is and not what a textbook says. And I honestly made that mistake and consistently made that mistake many times and many years ago, specifically as it applies to treating TMD surgically. And as you all know, or should know by now, I'm a 46-year practicing oral and maxillofacial surgeon who recently decided to pull the plug on doing any further oral and maxillofacial surgery and limit my practice and our business to the non-surgical treatment of TMD using an intraoral device and protocol. So, obnosis, and that is how all this started. I got to the point, and this is again described in a different episode in a different way, but I reached the point in doing surgery on the temporomandibular joint after 30 years and well over 2,000 tries and cases, and some cases were effective over a period of time, and some cases were not. But I got tired, frustrated, disenchanted with doing surgery when patients would be back, and not all of them, but many would be back in 6 months or a year or two with the same symptoms, and I did surgery for them. So I decided not to do surgery anymore and to look for myself to see if I could figure it out. And because of my broad background in the sciences, as degreed in dentistry, degreed in medicine, degreed in the academic sciences and research, I felt I had a broad enough background to take a look at this for myself. And I started by interviewing patients and looking at the patients and listening to the symptoms and encouraging the patients to tell me what was going on with them in their own words, and to see if I could figure it out. And actually, that's where I started. And within a short time, they gave me the key that opened the door to allow me to take a look at, for myself, what it means and how effective it is to disocclude the posterior teeth long enough to allow the inflammation to die down. And I found it was extremely successful according to a protocol, and it was off and running from there. And that ended up being the Urbanic device, which is now patented, FDA cleared and approved, and being done by many throughout the United States. So obnosis, I recommend when it comes to treating TMD, that you look at how to treat this and what is the best way to treat it. I don't feel I or my company or the device is in competition with anyone. I'm not trying to criticize during this. I am simply making an attempt to look at a solution directly in a manner that makes sense and is logical rather than things that don't. So TMD has many attempted treatments, recommended treatments. Some of them are getting very popular right now and well out of hand. And I'm going to talk about many of them. I've talked about many of them before, but this has to do with observing the obvious regarding treatment. Observing the obvious regarding using the Urbanic device, observing the obvious regarding a patient that you treat, however you treat it, and what happens. Because I got to the point, as I explained before, that it was obvious, observing the obvious. I had a returning list of patients after surgery who continued to have symptoms. Why would I want to do more surgery? So I got to the point where, observing the obvious, I decided to look elsewhere to try to figure it out. So let's talk about observing the obvious and how it applies to alternative treatments versus disoccluding the posterior teeth according to a protocol, unloading the joint and allowing the inflammation to die down. You need to observe the success. And so let's talk about night guards. I've been exposed since I was a dental student. First time I saw a night guard given to a patient was in the dental health clinic, and a night guard was given to the patient who had headaches. And I literally, at that time, I tried to figure out, how does covering the surface of the teeth make your headaches go away? Since then, I've seen a bazillion of them, literally a bazillion. Just yesterday, which was August the 8th, I had a patient come in with the typical, I used to call them brown paper bags. She didn't have a brown paper bag. She actually had a little purse, a paisley purse, and she said, I have 6 night guards in here. Would you like to see them? And she was sitting in my office for a consultation with a long history, 25-year history of headaches, earaches, jaw pain, and neck pain, etc. And she said, I had 6 of them. And I said, no, ma'am, I don't think I need to see them. I already know what's in them. But the point being that there were 6 dentists, or at least one dentist 6 times, which I doubt. I didn't investigate how many dentists made those 6 night guards. But 6 times a dentist made a night guard expecting something different, and then actually not understanding how or if or potentially why a night guard should help in headaches. But the point is, for 50 or 60 years, at least in my exposure to dentistry, night guards is the treatment of choice by half the dentists in the country in treating patients who come in and say, I have headaches, or I have TMJ. Or my jaw hurts, or my ear hurts, I think I have TMJ. Half the dentists make a night guard, give it to the patient, most of them not understanding anything about TMD or why a night guard might work. It's just the standard operating procedure to make a night guard. And of course, the other half of dentists in the country don't want anything to do with TMD because they feel nothing works. Doesn't work. We know nothing works. So that's night guard. So if you observe the obvious, that if you make a night guard and it is not effective, it doesn't successfully treat the problem, the symptoms, why would you want to make another one and another one, whether it be another one for the same patient or another one for a different patient? I think sometimes the night guard is the easiest way to get the patient out of the office. And I've heard that from my colleagues. I have heard them say that, my dental colleagues. I use the night guard, I give them the night guard, charge them $400 and hope they don't come back. It's terrible, but happens. Same kind of thing with occlusive equilibration. There's a thought process out there, a group of doctors who feel that occlusive equilibration, properly done, adequately done, with enough knowledge on occlusion, giving proper occlusion, will solve TMJ problems. Well, frankly, if you can equilibrate the occlusion adequately, that decreases inflammation in the joint adequately, you will get resolution of the symptoms. But my experience using Obnosis, looking at what's obvious, patients are in this office all the time who have been equilibrated and still have TMD symptoms, just like surgery. Frankly, throughout my career, not just me personally, I don't take it personally, but I and other surgeons were criticized bitterly because doing surgery on the temporomandibular joint was not conservative, considered, quote, conservative. And the meaning of that word is not very definite, but a lot of criticism went on. And I'm not saying it wasn't justified. What I am saying is cutting down someone's teeth significantly It's not conservative. And to continue doing that when it doesn't solve the problem is not looking at what is, observing the obvious. Observing the obvious, obnosis. Orthodontics, same thing, same concept. Here in Middle Tennessee, I continually hear about, and actually not third person, first person, patients come in. My orthodontist recommended I have frequent headaches, or I have TMJ problems, my neck hurts, my ear hurts, recommended I have orthodontics. Well, again, by placing the teeth and making the teeth in proper alignment, well, if that decreases inflammation within the joint, then I would expect you to have some resolution of the symptoms. However, the many cases that I've seen with patients who have had orthodontics and now they're sitting in my office with continued symptoms. And that gets into technical issues regarding how the orthodontist applies his orthodontic technology to solving the problem of the COCR discrepancy, centric occlusion, centric relation, which is functional malocclusion to one degree or another. COCR discrepancy is a functional malocclusion, and when it's big enough, it creates inflammation in the joint, and if that is not solved, then the patient will eventually, sooner or later, complain of TMD symptoms. So again, observe the obvious. If the orthodontist continues to apply orthodontics and continues to see patients back with symptoms, then you must conclude that it is not adequate or an appropriate treatment. Couple that are not frequently seen, but dry needling from the physical therapist. That has become a fairly common thing, especially for when they complain of upper back and upper shoulder pain. The physical therapist or the referring doctors don't even ask, do you have any of those other symptoms? Do you also have headaches? Do you also have ear pain? And don't connect the fact that upper shoulder pain or neck pain, which is the second most common symptom of TMD, is neck pain. Neck and upper shoulder pain is the second most common symptom of TMD. And for that, they may end up with a physical therapist who does dry needling. And the theory behind dry needling is sticking needles in the muscles will relax the muscles and therefore decrease the symptoms of tight muscles. And we already discussed muscles pull on bone, and where it pulls on the bone is where it hurts, not the muscle itself, where the muscle pulls on the bone. Well, if you look at that mode of treatment, how does that mode of treatment decrease inflammation in the joint? Obnosis, observing the obvious. And the last two, I want to try to talk about a little more extensively, and there are a few others, but let's leave the last two. The last two I want to talk about are drugs of various kinds and botulinum toxin, better known as Botox, and various other non-generic names. Botulinum toxin. Let's start out with drugs first, because I have I see and continued to see patients who have many of these symptoms, whether or not it's recognized as TMD or not. Many of them is not recognized as TMD. Many of them these patients are recognized as having TMD, TMJ, and placed on various kinds of drugs to treat their symptoms. The one that I think is the most damaging is opioids. And I have seen multiple patients that become addicted to opioids. And that's becoming more in the popular vision now of how damaging opioids are. And I think it is getting less and less common by my observation. But placing patients on opioids because they have maxillofacial pain or chronic neck pain coming from the temporomandibular joint, which does not address the inflammation, and the patient comes back after a period of time, still with symptoms, requesting more drugs, and then they become addicted, and then the unintended consequences of becoming addicted to opioids is well known, well established, and well described in the literature and on TV and on the internet. How terrible that is. And again, it is derived from not observing the obvious. Neuroleptics, psychotropics, same thing. I have heard many patients literally say, my physician, when I tell them about these symptoms, think I'm crazy. Now, I don't know how many of those physicians recommend the patient on neuroleptics, psychotropics, but I have many patients who have been placed on neuroleptic psychotropics for the symptoms that they describe to me, which after an examination and finding that the temporomandibular joints are inflamed, is obviously coming from the temporomandibular joint and the unintended consequences. And it all is derived from not observing the obvious, which is obviously looking at the symptoms and connecting the dots and say, this is obviously TMD, observing the obvious. And diazepines, for sure. And diazepines, being addicted to diazepines is extremely difficult and damaging to get off of. And then finally, I guess we'll talk about the botulism toxin, which I've tried to avoid as much talking about it as possible, but patients consistently come in who have been diagnosed by others or diagnosed by themselves, think they have TMJ, TMD. And I talk to them about what the problem is and how the problem is derived from inflammation within the joint, and how by unloading the temporomandibular joint, the inflammation just goes away. And more increasingly frequently, not once a day, but once a week. And we see 20 patients, 20 consults a week. So once a week, someone will say, well, I heard Botox is what they say, not botulism toxin. I heard that Botox can be used for this. And again, it gets down to observing the obvious. And I just did a little investigation on the internet, and there are substantial side effects, potential side effects, unintended consequences of Botox. It's well established that you can, with enough or placed improperly, actually cause nerve damage. It isn't that it decreases or goes away consistently in 4 to 6 months, but you can have permanent nerve damage with Botox, botulinum toxin, in and around the face. There are now claims and several legal claims that are out there claiming brain damage due to Botox. And of course, Botox is only temporary. And I speak now as it's used for TMD. I have no qualm. I have no question. I don't have anything to say about using Botox for your wrinkles. That is not what I'm talking about. But though it is the same product, it is the same botulinum toxin that is used for cosmetic reasons. It's used for claimed treatment of the temporomandibular joint. So observing the obvious, and I've done that many, many times in the practice, having people who come in with short or long histories of using botulism toxin, and they continue to have TMD, but they have to have their Botox injections periodically. And the worst I've ever heard was a woman who said that she had spent, she and her insurance company had spent $200,000 on Botox over a period of 10 years, having injections every 4 to 6 months for her headaches, which did not go away and sitting in my office with obvious inflammation in the temporomandibular joint and TMD. So with unintended consequences of using Botox, of now claims, legal claims in court that Botox can cause brain damage, and it's acknowledged that it can cause peripheral nerve damage. And again, I don't claim to be an expert on botulism toxin. All I'm saying is that we now know that those particular unintended consequences can occur. And does that warrant using that kind of treatment when it's obvious that decreasing inflammation within the joint, however you do it, best way is unload the joint, is the best alternative in treating not only pain in and around the head, headaches, right there, doc, where the temporalis muscle hurts, or right there, doc, where the masseter muscle inserts, rather than paralyzing those muscles to actually address the cause of the trismus of the muscles and decrease the inflammation in the temporomandibular joint. So, obnosis, observing the obvious. Just kind of recap. I mean, that's how I really got into this. I decided to observe the obvious, to sit down with the patients and observe them, to talk with them, to listen to their symptoms and whatever they had to say about it, and started collecting the symptoms that all came together. And then I had to figure out how all those symptoms actually originated. All of those symptoms originate from inflammation within the temporomandibular joint. And that's outlined and clarified extremely well in the course that I have online describing how and why to use the Urbanic device and protocol and unload the temporomandibular joint long enough to allow the inflammation to decrease, and do it continuously, like persistently, forever, using the device at nighttime only, but using the device at the beginning 24/7 until you can get the inflammation to decrease as rapidly as possible, and then nighttime indefinitely. That's the protocol. So, observing the obvious, to look rather than to listen, to look rather than to just think about it, to read articles, to kind of look at all the different statements and studies and recommendations by others, to see what you see and not what someone else wants you to see. And I think that applies to Botox and botulism toxin. The companies that make these products, and the use for the products for the temporomandibular joint is not according to what the original intention of Botox was meant to use for, but it is used increasingly frequently and marketed with a huge amount of dollars applied to marketing patients with headaches, which is, extremely common problem. And everyone with a bad headache now calls it a migraine, which is not true. You have bad headaches, bad headaches. Is it a migraine? That's debatable. That's a big debatable, and there are great studies that need to be done about that. And I hope in the future, when resources permit, that I can do additional studies on that. The company can do additional studies. So, observe the obvious. Look for yourself. And if you find it true, and then it is true for you, you see it. And if you don't see it, then it's not true. It's not happening. It's not happening. So for today, I am Tony Urbanic. I look forward to the next time I'm able to share some knowledge with you. If you'd like to join our network of doctors who use our device and protocol, you can look us up on the internet at www.tmjservices.net. You can talk with me directly via the internet at tony@tmjservices.net. You can ring up our Director of Marketing and Education, Naomi at tmjservices.net. And until the next time, I wish you a very successful and productive week.